All right, let's dive into a super important topic in musculoskeletal trauma, ankle joint fractures. We're going to break down the key concepts you absolutely need to nail for your exams and, more importantly, for the wards.
Okay, first things first, let's get the definition straight. An ankle fracture is always an intra-articular injury. Now, why does that matter so much? Because we're not just talking about a simple crack in a bone way out in the shaft somewhere. Nope, this is an injury to the joint surface itself that has huge implications for everything from healing to long-term arthritis risk. And you gotta remember, the bones are only half the story. The ligaments, they're almost always involved, and that's a massive piece of the puzzle.
So this naturally leads to the big question, right? You're in the ER, you've got this x-ray in front of you. What do you do? How do you look at this pattern of fractures and figure out what it all means? And most importantly, how you're going to treat it? And the answer, thankfully, is a really elegant system called the Weber classification. You know, its genius is really in its simplicity. It takes what looks like a super complex three-dimensional mess and boils it all down to one single relationship. And that is, where is the fibular fracture in relation to that all-important tibiofibular syndesmosis?
Okay, so here's the entire system on one slide. It's beautiful, right? It all comes down to one question. Is the fibular fracture below, at, or above the syndesmosis? Just knowing that one thing tells you basically everything you need to know about how stable or unstable that ankle joint is. All right, let's break it down, starting with type A. The fracture is below the syndesmosis, and this is the key part. Because it's so low, those critical stabilizing ligaments, the syndesmosis, the deltoid ligament, they're totally fine. They're intact. And that's why this is considered a stable injury.
Next up, we've got Weber type B. Now here, the fracture line cuts right at the level of the syndesmosis. The key word for type B is variable. You really got to burn that into your brain. The syndesmosis might be okay, but it also might be partially torn. You just don't know for sure from the x-ray alone. This is where you have to be a detective and really assess for any subtle instability.
And that brings us to type C. With type C, the fracture is above the syndesmosis. And this is the one where there's no question, no variability. It is always an unstable injury. Why? Well, think about the force. For the fibula to break that high up, the energy had to travel right through the syndesmosis and up the interosseous membrane, tearing everything in its path. This is unstable, period. And hey, a quick pro tip, always get full-length films, because you do not want to miss a Maissoneuve fracture, which is a classic Weber C injury.
This quote really just nails the whole concept. It's so simple. The higher the break on the fibula, the worse the damage to the syndesmosis. It's a direct relationship. High fracture equals high instability, low fracture equals low instability. It's really that straightforward.
Okay, great. So we've classified it, Weber A, B, or C. Now for the million-dollar question, what do we do about it? How does this classification actually guide our clinical decisions? Let's talk about turning this diagnosis into a concrete action plan. Honestly, the first big decision point is actually pretty simple. It all comes down to one thing. Is the fracture displaced? Is that ankle joint still perfectly lined up, or has it shifted? If everything is perfectly anatomical and it's a stable pattern, great. We can probably treat it conservatively with a cast. But the moment there's any displacement, that's an automatic ticket to the operating room. And when we do go to the OR, our goal is absolutely non-negotiable. We are aiming for perfection. Because it's an intra-articular fracture, you cannot leave any step-off or gap in the joint surface. It has to be put back together perfectly, what we call an anatomical reduction. Then we fix it with plates and screws so it's rock solid. And why do we do that? So the patient can start moving early and avoid getting a stiff, painful angle down the road.
So, what does that surgery actually look like? Well, here's the standard game plan. It's a step-by-step process. Step 1, you always fix the lateral malleolus first. Get that fibula back to its proper length and rotation. Step 2, you turn your attention to the medial malleolus. And finally, step 3, and this is only for the unstable ones, you address the syndesmosis. Now listen up, because this is probably one of the most critical points of this entire talk. For those unstable type C injuries, just fixing the fibula is not enough. You haven't solved the core problem. You absolutely must put in a syndesmotic screw. This screw acts like a temporary ligament, holding the tibia and fibula in their perfect relationship, stabilizing that whole ankle mortise and giving the real ligaments a chance to heal properly. All right, we've covered a lot of ground. Let's boil this all down to the absolute key take-home messages. This is the stuff you need to remember for your exams and for when you're on the wards.
So, here it is, your cheat sheet. It all starts with the syndesmosis. Its integrity is what determines stability. And the Weber classification is our best tool, using that fibular fracture level to tell us what's going on. Remember, type A, below the syndesmosis, it's stable. Type B, at the level, stability is variable. Be suspicious. And type C, above the syndesmosis, is always unstable. From there, your treatment path is clear. If it's not displaced, you cast it. If it is displaced, you operate. Simple as that.
So if you remember only one thing from this whole explainer, let it be this. When you look at an ankle x-ray, your eyes should go straight to the fibula. Find that fracture, because its location, its relationship to the syndesmosis, that single detail tells you the entire story of the injury's stability and points you directly to the right treatment.